Yeah, well, thank you very much for having me. I'm going to indeed talk about the continuous thermodilution, and we already heard that there are actually two methods to investigate the microcirculation more specifically. First, we already heard about the Bolus thermodilution, and I'm going to explain you more about the continuous thermodilution technique. And what you actually need to measure the microcirculation using continuous thermodilution are a couple of things. First, you need the Abbott pressure wire, and it has to be specifically from Abbott because that pressure wire has a built-in temperature sensor, which you need to investigate the microcirculation. Next, you need to install the CoroVentus software in your CAD lab. You then receive this little CoroHub receiver that picks up all the signals in your CAD lab and transfers them to either a laptop in your CAD lab or directly to your CAD lab monitor. And this is then the screen on the right, what you see when you're performing those measurements in your CAD lab. You also need a ray flow infusion catheter. This is a monorail infusion catheter that can be advanced as a monorail infusion catheter over your pressure wire. And in the middle image, you see such a schematic view of how that looks like in your coronary artery. You have the guiding catheter, you then have the ray flow. In the proximal coronary artery, it's equipped with a little radiopaque dot, as you can see here, that indicates the tip of the ray flow, and you advance it over your pressure wire, and the pressure wire is located distally in your coronary artery. That ray flow catheter is attached to a saline pump, which is of course outside of the body, and you set the infusion for an LAD at 20 milliliters to 25 milliliters per minute. Then when you start the infusion, this is an enteral catheter, you see there's incomplete mixing, but when you use the ray flow catheter, there's direct and homogeneous mixing of the blood and saline at the tip of the ray flow, because there are 4 infusion holes at 0, 90, 180, and 270 degrees that guarantee the even spread of saline in your coronary artery. So you can see the direct mixing, and that saline alone creates maximum hyperemia without adenosine or rapid scan or anything. It's very thoroughly investigated that it creates the exact same hyperemia as adenosine. So the advantage is that your patient doesn't experience anything. They don't feel the saline with the same experience as you can get when you use adenosine. And the whole method is based on the following equation. I'll explain it to you. The software does everything for you, but it's also always nice to know what you're measuring. You start the infusion pump at 20 milliliters per minute. The ray flow starts infusing, and you measure the temperature distal in the coronary artery when the blood and saline start mixing. You always zero at body temperature. So let's say the distal temperature in your coronary artery is 0.5 degrees below body temperature. Then you measure the infusion temperature when the saline enters the coronary artery. Let's say that's 5 degrees below body temperature. And you know the rate of your infusion pump because you set it yourself. So then you can make this, this formula. This 0.18 is a correction factor for before the difference in specific heat between blood and saline. And then you have your absolute flow in the coronary artery. As I already said, of course, the software does the calculation for you, but it's good to know. This is what it looks like. Everything is equalized. The body temperature is set to 0. You start your infusion of the saline. The temperature drops, and you see a very nice, steady saline hyperemia without adenosine. Everything is stable. You have measured your infusion temperature of your distal temperature. Then you pull back the sensor to the tip of the ray flow, so to that little radiopaque dot I just showed you, and then you measure your infusion temperature. When everything is stable again, you stop the infusion, everything turns back to normal in seconds, and then you get your actual blood flow in milliliters per minute. And because you measure distal pressure as well, according to Ohm's law, you can also get the resistance of the microvasculature in Wood units. As you can see here, from one measurement, you have the absolute flow and the resistance. So in our daily practice, for example, we have a 60-year-old female. She already visited our outpatient clinic in 2019 with typical angina. We performed 2 SPECT scans on her and an echocardiogram. It was all normal. Then she came to my outpatient clinic and I talked with her and I told her maybe we could do an angiogram with coronary function testing. Her coronary angiogram was completely normal. And in Eindhoven, we always do both because it takes 6 minutes and then you're done and you know everything. Here we do the absolute flow measurement and we also perform IMR because we also do have a lot of research purposes and it's always nice to have both. And in this patient, all values are abnormal. So the resistance is too high. The cutoff value is 470 Wood units. The IMR is too high and the MRR, I'll explain to you later, is too low. So this patient was treated with a combination of calcium antagonist and nicorandil, and she was free of complaints. We do have normal values for the continuous thermodilution. They were published in 2001 already. I won't bother you with the whole table, but a normal value for LAD is below 470 Wood units. It's not only investigated by us, but also by the colleagues in Madrid. They compared absolute flow with IMR and they made a ROC curve of the optimal cutoff value with an IMR above 25, and they also found this value. That being said, all measurements from the microcirculation, IMR, absolute flow, are dependent on the distal territory. So if you have a small circ, small perfusion territory, your resistance is high. So that's a little bit difficult because the value can change. It's also a little bit dependent on epicardial disease, autoregulation, stress. So that's difficult. And exactly for that reason, a new index is published, and that's called the Microvascular Resistance Reserve. All the high impact journals are talking about it, publishing about it all the time. It's this week's JACC topic of the week. Also, Valentin Fuster talked about it in his podcast this week. It takes 16 minutes, so I can't show it to you right now, but if you're willing to listen to it, it's very nice. And what is MRR? It's difficult to explain that to you in a couple of minutes, but I'll do my best. But we can talk about that for hours.
But this is the message that they carry home. On one hand,
in short, the MRR, what we actually want to define the microcirculation precisely is something like the true resting microvascular resistance divided by the hyperemic resistance. But that being said, is that the resting microvascular resistance is always influenced by some kind of epicardial disease. So if there is a very slight difference between PA and PD, what the microvasculature does, because of the autoregulation, diminishes its resistance to keep the flow constant. So what you actually measure with resting microvascular resistance is sort of a compensated resting state due to your autoregulation. In a hyperemic state, you do not have that problem because then you exclude the autoregulation, but the resting microvascular resistance is lower. So what we need to measure is not this, but the ratio between resting and hyperemic microvascular resistance in the theoretical case that the epicardial vessel is completely normal. And that is the MRR. It's the flow in hyperemia divided by the flow in rest, corrected for the FFR, so the driving pressures. And you can very nicely do that with continuous thermodilution. You can measure rest with the method I just showed you, but then you put the infusion pump at 10 milliliters per minute. It was very extensively investigated by Bernard Bruyne et al. that does not create hyperemia at all. Then you switch the infusion pump to the hyperemia, 20 milliliters per minute, and then you have your flow in rest and during hyperemia, and you can calculate MRR. And an MRR below 2.1 is abnormal. also published in JACC. And you can even do that within one run, depending a little bit on your infusion pump. But I know a METRED pump can be programmed in advance. So then you have your 10, 20 in one run, and you get everything in the same measurement. So that's very easy when you know how to do it. And this is the central illustration of that JACC paper I just showed you, that if you have a patient with ANOCA, with normal coronary arteries, we should really pay attention to the pathophysiology. Is there spasm? Is there microvascular disease? And that continuous thermodilution is a very elegant and, most importantly, operator-independent way to assess the microcirculation. That's what I wanted to tell you.
Nell, thank you very much for this talk. You presented an innovative technique that actually you contributed a lot in its development. Any questions from the audience for this talk or for Bolus thermodilution that was presented earlier? I have a talk that actually combines both techniques. So what is the advantage of continuous thermodilution compared to Bolus thermodilution?
Well, the first advantage is that continuous thermodilution is completely operator independent, because when you start an infusion pump, you cannot do anything. And with bolus thermodilution, you have to give the boluses yourself. The values that the person just showed are very equal, but you always measure 3 times and you can replace the values as you want. So sometimes you have a lot of difference between the values and then you're choosing, which one do we have to replace, which makes it less reproducible than this. That has been shown very extensively. And the second one is that this measurement measures actual flow, and IMR is just a surrogate of flow, because you measure the mean transit time, assuming the vascular volume is the same, which of course is. So yeah, I think it's a little bit of a more clean version to assess the microcirculation, but it doesn't make IMR awful, of course. And that's also the reason why we still measure both, because continuous thermodilution is still in its baby shoes. We're running 20 years behind on IMR because that was invented in 2003. All new techniques need 10 to 20 years to become popular. So we're always measuring both to see whether the values point at the same direction.
So continuous thermodilution then is more reliable. But how practical is to do it in the cath lab?
Yeah, well, it is true that you, of course, need to invest in your cath lab, but you already need the Abbott pressure wire and the software to measure the microcirculation anyway. But you do need the ray flow. So that's a little bit more expensive, of course. But I think it's worth it because, in our humble opinion, I think MRR is the future. But we will see that in 10 years.
I think Eurocraft, this large registry, will give us the answer for this.
Yeah, Eurocraft, yeah.
Any question?
Yeah. Congratulations for your talk.
Thank you.
It was really exciting. I have some questions. Is this microcatheter commercially available, or
Yes.
it's only for research purposes?
No, it is certainly commercially available. Hexacat from Paris is the producer from that catheter. But if you participate in large European registries, let's say the Eurocraft, we're still looking for centers who want to participate, then you receive the ray flow catheter or the costs for it, and then you can very easily participate without spending extra money.
Does the profile of the microcatheter affect negatively our results, or it's so small?
It does affect when you measure absolute flow, you also receive an FFR value, as you can see here in the top. Because you have a small catheter in your proximal coronary artery, this does create a small gradient because it's in there. So we've investigated how much the FFR is actually lower. It's about 3 to 4 millimeters mercury. So this FFR is a little bit lower. But that being said, your MRR is not influenced by the presence of the ray flow, because both your flow and your PD are equally affected by the presence of the ray flow. So the MRR stays the same. When both values of the equation are equally affected, it stays the same. But your FFR, what you see here, is in real life a little bit higher. But these patients have normal coronary arteries. So.
And the last one, when we have a moderate stenosis across the epicardial vessel, can we trust precisely the measurements of IMR using this method?
If we then trust the measurements of IMR?
It's not healthy at all, but there is a moderate stenosis on epicardial vessel. And
well, the MRR isn't affected by epicardial stenosis, but what I explained, the flow IMR is. But what you then can do is you can also advance the ray flow beyond the coronary stenosis and then still measure the distal part.
Dr. Τερεντές, Príndžιος, you have a question.
One question. For example,
yeah.
Yeah. And that's the case, then we have some kind of way of assessing market therapeutic target.
Yes. Yeah, we did perform a study. It's called the ADDED study. It's published in JACC or European Heart Journal. I have to be lie about it. But we did treat patients with coronary microvascular disease with the calcium antagonist, with diltiazem at the highest dose. Then we met, and the other half of the patient with a placebo. Then they all came back to our cath lab 6 weeks later to reperform the measurements, and unfortunately there was no difference. It's also referring to the question you earlier received. We still do not have treatment, but the studies in these patients are difficult because they all have to revisit the cath lab to perform all these invasive measurements again. And in our daily practice, we often make combinations of a calcium antagonist with nicorondil and all those combinations. And yeah, this is all not investigated, still in the baby shoes. So I think we have a lot to do, and certainly don't think there's no treatment at all, because I don't think we don't know yet. I do think we don't know yet. And not a lot of placebo-controlled trials have been performed. When they remeasure, they are all based on angina scores and not on remeasurement. That's the only study who did that.
Dr. Brandas?
Congratulations, very, very nice presentation, and definitely continuous thermodilution overcomes some of the limitations of Bolus. I have read quite a few papers in the past comparing adenosine FFR with exercise FFR. They put the patient on the exercise on the table, and they found only a moderate correlation between the adenosine FFR and exercise FFR. What about the microvascular function? Are we measuring microvascular function accurately when we give adenosine and reproduce what actually happened on exertion? Or this is another limitation that we have to take into consideration when we're doing these measurements, and take also into account patient symptoms to decide about treatment?
Sorry, recap the question.
Difficult question, Christian.
Yeah.
But this is something that we have to take into account. Adenosine FFR is not actually the FFR that you can get when you're exercising.
Yeah. We did not investigate it. Well, in this method, we do not use adenosine at all, but it is compared with adenosine. Saline hyperemia with adenosine is completely the same. So, we don't know.
The problem with exercise FFR is that it's very difficult to exercise the patient on the table. I mean, it's doable. Dr. Kibble has done it multiple times, and other cath labs, for example, Javier Canet is doing it, but obviously it's not practical and it's not transferable to everyday clinical practice. But it's a very good thing to have in mind. Eros, do you want to do the last question?
Yes. Congratulations, very nice presentation,
Thank you.
Ms. Keulards. I think in this discussion we worked out why or what is holding us back for absolute flow measurements here.
Yeah.
And it has become in the Netherlands, as I know, it has become standard of care. So you can put it in the package of many university hospitals at least, or centers as yours,
Yeah.
who's very interested in this and not pay. But the price of 600 to 800 euros, depending on for this ray flow catheter, is something which holds us back. And hopefully we can work here with the people who are interested in this field to make the standard of care. Obviously, that's the way forward. Maybe for the talk before, which was a really good talk as well with the Bolus thermodilution, one thing I'm skeptical about is the adenosine intracoronary bolus in this whole measurement. I think this brings too much noise into the measurement. I don't know how with my two hands or with even four hands, it's going to make it very difficult to understand what you're measuring with two boluses, one adenosine and then quickly the IC, the flushing, different things which would, I think, influence the measurement. That's just a small comment. Thank you.
Thank you.
Thank you very much.